So my presentation is about medicinal cannabis research in palliative care. So I think as other people talked about this, the clinical problem in advanced cancer is that in palliative care, people suffer from a lot of multiple symptoms, not just one symptom. I guess most of the randomized controlled trial research has just been done around pain as such, and little has been done in other symptom areas. So we've looked at this more around the idea of multiple symptoms and the benefit of or not of cannabis in that area. So there's still unmet needs for symptom control. There's a strong patient demand for cannabinoids, a strong government push, but still at the moment there's a very weak clinical evidence base, and I guess that's best seen by the fact that none of these medicinal cannabis products are on the ARTG or PBS as yet. So one of the things we looked at is, this figure comes from a study that was done in Seattle, in Washington, I think it was, where they looked at reasons for cannabis use among survey respondents. And as you can see, people use it for a variety of different reasons, not only physical symptoms, but neuropsychiatric symptoms. So and also one of the things when we were first starting to look at trials was this question about which way do people want to take cannabis from a patient point of view. And I think initially people thought a lot about this idea of vaporizing cannabis and associating with smoking cannabis. But in fact, this is done in an outpatient setting in Australia, and they found that most patients prefer to take it by tablet or capsules, and mouth spray being the second one, with a variety of different ways after that. And as was described, I think the last talk about TGA guidelines, and currently the guidelines around that, the first recommendation is to try and enroll patients in clinical trials, medicinal cannabis and palliative care. So we've taken that on board, in the MARTA and in Queensland here in Australia, that we're doing a number of different trials. The first trial we did, we were able to get an MR Medical Research Future Fund grant in 2018, and we'd already started doing this study somewhat, which is an open label pilot study testing the feasibility of assessing total symptom burden in trials of cannabinoid medications in palliative care. So, and then I'll talk mainly about that one, but these are the next two studies that we're currently participating in and running, and they're both randomized controlled trials. One is CBD oil versus placebo, and the second one is CBD THC 10 to 10 milligram per mil versus placebo. And they're both published study protocols, which you can look up in these journals. We're aiming to, in both of them, we're aiming to recruit approximately 150 participants, and we're almost halfway there in the first trial, and the second trial has only started this year, so it's a bit slower recruitment. And we're also, at the same time, we really wanted to look at this idea of the views of participants and non-participants towards medicinal cannabis. So in all these trials, we've asked people if they wanted to participate, if we fit the criteria, and some people do want to participate and some people don't. And a really important part of what we're trying to do is actually work out what people's experience is, what are the reasons for going on trials and not going on trials, and what are the reasons for taking medicinal cannabis products or not taking them. And we're aiming to recruit somewhere around about 40 patients, or 48, I think it is, patients. And again, so probably about 2/3 of the way there in the qualitative studies. So just briefly to go over the open label study we did, which has got the results for. This was just a prospective 2-arm study of escalating doses of CBD and THC oil. These were really just chosen because of what was the available supply for what we could get for free from companies to give to us, to give to the patients during this trial. It was just a pilot study. And I suppose this is the outcome measure, and the outcome measure is what's called the Edmonton Symptom Assessment System. And this is a very widespread assessment system used in palliative care settings, often used in trials. People often use one measure, such as pain, and there's a variety of ways to measure pain. This is an outcome measure that looks at a variety of different physical symptoms, plus some psychological symptoms, plus well-being, and you get a score out of 90 overall. And what we did in this trial, we had 33 invited to participate, 27 were screened, 6 were ineligible. Then we had 21 patients start, 16 CBD and 5 THC. So the CBD was pure CBD, 100 milligrams per mil, and the THC was pure THC. And we'll talk about the doses. So our primary outcome measure was at day 14, and that was an improvement in, this was a feasibility study, so how many people stayed on. The second outcome measure was to do the improvement in the total symptom assessment burden measured by the Edmonton Symptom Assessment Scale. So for us, it was good that 18 out of 21 made it to day 14, because one of the measures was to really see what the feasibility was. And then only 8 people made it to day 28, which people stayed on until. So just the baseline characteristics, more females than males, and that represents really at the Mater, where this was run mostly in Brisbane, has a very large breast cancer and ovarian cancer population. The median age was 57.5. The oral morphine equivalent daily dose was 140 milligrams. So in this first pilot study, people could go on it if their THC urine test was positive. And there was about 19% positive. In our randomized controlled trials, you have to have a negative THC urine test. So drug allocation was 16 to CBD and 5 to THC. That was really based on what was available to us. The AKPS is a measure of performance status. So 100 is normal performance status. 0 is if you're actually dead. 50 is bedbound more than 50% of the time. So 70 is reasonably good in a palliative care setting. And the total symptom distress score, which is TSDS, is a score out of 90. And the mean here was 41.1 with a range of 14 to 64. To get into the study, you had to have at least a minimum of 10. Between about 30 is an average in most studies. So 40 is quite a large symptom burden. And as you can see, there's a mixture of patients there, a large proportion of breast cancer patients. So we had 21 patients enrolled, 18 completed, day 14. So 9 out of 21 met the definition of response. So on that Edmonton Symptom Assessment Scale, if you improve your score of 6 or greater, has been defined in studies as a marker of clinical significant response. The medium doses tolerated were CBD 300 milligrams a day and THC 10 milligrams per day. There's a wide range there. Our minimum range of CBD was 50 milligrams per day and maximum 600. And the THC, the minimum range was 2.5 to 30 milligrams, and that was the range 5 to 30 milligrams was what people ended up on. So the mean change from baseline was minus 5.8, which is very close to the clinical significant. I guess what we found was that there was a significant decrease on the emotional ESAS subscale, which just measures anxiety and depression, and no adverse event greater than grade 2 were reported. So this is a waterfall plot, which often looks better than it represents, because people who do not complete are not included in this. But the red line across there's a line at 0, and the red line underneath that represents 6, which would be clinically significant improvement. So, and blue, if you can see it, is CBD, and red is THC. So if the score is going downwards, a negative score, that's an improvement. As you can see, there's a number of people improved, and some had scores going up. I suppose, yeah, the importance of doing placebo-controlled studies in this area, one is obviously there's a large placebo effect of any medication in the palliative care setting, but particularly the other thing that that happens as well is that symptom burden increases as they progress from their cancer, and so it's really important to control for that as well. So these are changes for individual ESAS symptoms. Just remembering this was not powered to find a significant difference, but it has helped us get an idea of what symptoms may or may not be improved overall, given the fact that there's a lot of people talk about case studies, anecdotal evidence, but very few published studies, and not very many studies done in CBD and palliative care patients. So I guess just generally you can see going down there, there's been some improvement, most of them across the 0 baseline. And as you can see, anxiety and depression have a significant effect there. And the other one, which was really interesting to us, was appetite, given that most of the patients are on CBD, not THC, although not quite significant on that one. So we also measured anxiety and depression and quality of life, and that was done by 2 measures. One is called a DASH-21, which is a measurement of distress, anxiety, and stress scores, and it showed there the depression and stress score both had a significant change. Well, the anxiety scores didn't have a significant change, but overall the total scores had a significant change, and there was no change in overall quality of life as measured by the ERTC measure which we had. In terms of adverse effects graded worse than baseline, the most common one was drowsiness, and there was a variety of other ones which, again, it's very hard without a placebo control to really know how much of this is due to medication, how much is due to other drugs, how much is just due to disease progression from that point of view. So there's quite a number of scores, although none were greater than grade 2. So they weren't too, they were relatively well tolerated by the patient. For us, there was no psychosis. There was a few changes in nausea and vomiting from that point of view, and mood, but nothing in particular. So I just want to move my thing here. I guess overall, what this confirmed was that feasibility, that 86% of people were able to complete a primary outcome measure at day 14, which was important to us to know for the randomized controlled trials, how many people are going to get, expected to get to day 14, which is our primary outcome measure. And some people may think that day 14 is too short, and some people may think it's too long. I guess the issue with day, in these studies, is really trying to find the balance between dropouts and have enough people to measure a primary outcome. The mean reduction at day 40 to 5.8 is very close to the clinical significant outcome measure. So that was, I guess, reassuring for us that we were replicating what other people had found. The response rate under 50%, just under 50%, may have been less than anticipated, but that's a intention to treat response rate. So that starts with everyone who's included in the study and taking into account dropouts are included. So if you're a dropout, you're a non-responder. So that's only the people who responded from that point of view. So that was reasonably what was to be expected and positive going forward. What we found was interesting was the improvement in emotional ESAS scores, and the medication was generally well tolerated. The major adverse effect being drowsiness, that seemed to be dose related, and for each person who got drowsy, we were able to reduce the dose and manage that okay. So as well as doing that trial and the randomized control trials we're doing, we're also, the way we prescribe it, cannabis, after the trial is we offer patients to have it through an authorized prescriber scheme, which is, I think, a little bit different to a lot of people do in Australia at the moment. This is helpful to us, one, in the sense that we obviously don't have to apply for an individual patient after the trial. We have a variety of products available, which we've got there, which people are able to go on. And what we're doing is having a post-trial audit to follow up these patients on an ongoing basis, just to see what their outcomes are. So far, we've had about 43% of people have requested ongoing supplies. There's been a variety of different drugs we use. Some people use the pure CBD. That's been beneficial for some people, but it's quite expensive for others. We sometimes use the sprays. Some people prefer a one-to-one, and there's a variety of those. I guess the major issue for a lot of people is cost. That just lists out the same medications in a different form. And for everyone, who goes on to a post-trial or authorised prescriber or even SAS, everyone's required to have a consent form, which is we do for that, and this is okay. This is a post-trial audit that we're trying to do to follow up people from that point of view. I've gone a bit quick there, but just to give a description of the qualitative study that we're doing. So we've done about 35, I think it is, out of about 48, and it's interesting that people are on the study and people are off the study, and there's a variety of different reasons that we're finding why people wanting to go on to cannabis, wanting to participate in cannabis trials, and why they don't want to participate. And I guess one of the interesting things for us so far has been that for a lot of patients, a really motivating factor is family, and often for older patients, it's children who are saying they should try this. So it's a different demographic, because that's not normally the sort of motivating factors for going on trials that we see. There's certainly a recognition of different celebrities promoting cannabinoid medications, and that has meant that some people know about it more and are able to go on it from that point of view. The trial itself is over 4 weeks, and initially people had to come in every week. With COVID, there was a pause of the trial during COVID, and as a result of COVID, what we've done is they only have to come in every second week of the 4-week trial, and that's helped some people, because coming in every week can be a burden to patients. And so coming back more often was a burden for some people and didn't want to participate from that point of view. And I guess the other reason was that the cost post-trial was an issue for patients, and so they didn't want to go on a trial and find they thought that it benefited them, and they were going on to not being able to afford it post-trial from that point of view. So we're still trying to finish off that qualitative study and see how that goes from that point of view. In terms of randomized controlled trial, the recruitment's going pretty well. I guess the major one of the major reasons for people not wanting to go on THC CBD study is driving, and the fact that they are told that they cannot legally drive whilst they're on a THC product, and that puts a lot of people off that product at the moment on the trial. Otherwise, we're recruiting quite well to both studies.